Hello, can you hear me?
Assalamualaikum.
Waalaikumsalam.
And we start testing the audio and slides, those who are presenting. Your voice, you just test your voice to others because your voice is a bit slow to me.
Hello?
Okay,
Is
more
it
clear.
clear?
Yes.
Okay. Okay, I will try share the slide.
Hello?
Okay, can you see the slide?
Yes.
Try to make it in PowerPoint slideshow. Okay, all right. See. Okay, all right. Can see. Just move on to other slide. Just try this. Yeah. Okay. All right. Okay. Okay. All right. So is most your colleagues, everyone is in already?
There's 30 more.
Okay, we'll start in a minute.
Hello? Hello? Dengar?
Yes, yes, we can hear you. Okay.
Okay.
Just a question. You already can go to hospital, eh?
Next week.
Next week?
Yes.
Okay, all right. So, okay. And by next week, seminars also can be done in hospital, is it?
Yes.
Okay, all right. I think we can start.
Okay. Everybody can hear me right?
Yes.
Okay.
Yes.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good evening to Dr. Salehin and also my fellow friends. So today, there will be three presenters that will present about the disease in nephrology. Next. So the topics that we will present after this are nephrotic syndrome, acute glomerulonephritis, and also UTI in childhood. Next. So my name is Ahmad Zaki Iqbal, Bizukarnain, and I will be presenting about the nephrotic syndrome. Next. So nephrotic syndrome is a clinical syndrome of massive proteinuria, which can be defined by four things, which are proteinuria, more than 40 milligram per meter square per hour, or an early morning urine protein creatinine index of 200 milligram per millimole. And the second one is hypoalbuminemia, which is lower than 25 grams per liter, hypercholesterolemia, and also edema. Next. So for the etiology, it can be classified into two classes. The first one is primary idiopathic nephrotic syndrome, and also secondary causes of nephrotic syndrome. So the example of primary causes of nephrotic syndrome are minimal change nephrotic syndrome, primary focal glomerulosclerosis, membranoproliferative glomerulonephritis, and also idiopathic membranous nephropathy. And for the secondary causes includes SLE, venous Schwann purpura, chronic infection, allergy reaction, and so on. Next. So for the pathophysiology of nephrotic syndrome, the leakage of the protein into the urine can be caused by the increase in glomerular permeability. So, so there are many causes that can increase the glomerular permeability. However, for tonight, I will explain about the changes in podocyte. So as we all know, podocyte is one of the layer that form the glomerular filtration barrier aside glomerular basement membrane and also fenestrated capillary endothelium, as you can see on the picture at the top right. So we can see that podocyte the podocyte is located at the Bowman capsule. So this podocyte have intercalated podocyte food process, and this are connected by the slit diaphragm. Which is the size is about 55 to 45 nanometer. So what happens is that the slit diaphragm will allow the substance to be filtered from the blood vessel to the kidney. So what happens is that when there is any injury or also any genetic mutation that can affect any parts of the podocytes, such as slit diaphragm and also the nucleus and also the actin. So it will cause the podocyte to be abnormal and can cause the decay, can disrupt the permeability of the glomerulus. So when there's any this condition will increase the glomerular permeability and cause the increased filtration of the plasma protein, which include albumin and so on, and also it can cause urinary losses of protein that carries the hormones, metals, and vitamins. And and due to increased filtration of plasma protein, so more protein will be lost from the blood, and can cause and more protein will be collected in the urine and can cause proteinuria. So when when uh, protein when proteinuria occur, so um, the tubule will try to reabsorb back the filtered protein, and it can lead to tubular damage and can cause tubular dysfunction. And also, the increased tubular reabsorption of filtered protein can cause tubular catabolism of albumin, and can cause hypoalbuminemia. And hypoalbuminemia can also occur due to, as I said before, the proteinuria. So more protein is excreted through the urea, so less protein will be available in the blood and can cause hypoalbuminemia. So when hypoalbuminemia occur, the oncotic pressure in the blood capillary will be reduced and can cause the leakage of the from the bloodstream into the extra extracellular matrix and can cause edema. And also, due to low level of albumin, it will try to compensate the loss of protein by increasing the hepatic synthesis of lipoprotein, in which it can lead to hypercholesterolemia, and eventually it can lead to lipiduria. And also, when there is increased filtration of plasma protein, it can reduce the cellular immunity due to loss of immunoglobulin, and also alter the turnover rates of immunoglobulin, and can increase the risk to get the infection. Next. So for the clinical features, we can for the clinical features, the first thing that we can notice is edema at the periorbital region, particularly in the morning. And also we might see any scrotal or vulvar, leg and ankle edema. As we can see in the picture, there's scrotal edema. And also we can notice proteinuria, ascites due to edema at the abdomen region, anorexia, malaise, abdominal pain if there is any infection at the peritoneum, peritonitis, and also it can lead to elevated blood pressure, and hematuria can also be seen, especially in primary nephrotic syndrome, and also can cause diarrhea, intestinal edema, and also patient might have respiratory distress if there is any pulmonary edema or pleural effusion. And as I said before, the patient might be affected and might have peritonitis, arthritis, or sepsis. Yes. So to diagnose nephrotic syndrome, so we need to do some investigation. And the main one is urinalysis, in which from dipstick test, the result should be 3 plus or 4 plus proteinuria. And also there might be some microscopic hematuria in 20%. And also for the investigation such as quantitative urine protein excretion, the spot urine protein creatinine ratio must be higher than 2.0 or 2.0. And also for liver function test, we can see the serum albumin will be lower than 25 grams per liter. And if there is any hepatitis B and C infection, the AST and ALT might increase. And for serum cholesterol, the triglyceride, low density lipoprotein, and very low density lipoprotein might increase. And for HDL, high density lipoprotein, it might be normal or low. And for renal profile, the creatinine might be normal or elevated or it can be elevated in any impaired renal function. And for food blood count, the hematocrit might increase due to hemoconcentration. And also increased white blood cell may indicate infection, and platelet count may increase also. And besides that, we also did some investigation to exclude any secondary causes of nephrotic syndrome. as I said before, the secondary causes, the example of secondary causes are SLE, glomerulonephritis, and so on. So some of the investigation that we can do, such as anti-nuclear factor, anti-BSN, anti-double-stranded DNA to exclude SLE, serum complement, C4 level to exclude SLE, and also post-infectious glomerulonephritis, anti-strep, so ASOT type to exclude post-streptococcal glomerulonephritis, and also we also do renal biopsy if there is an for condition which are steroid-resistant nephrotic syndrome, persistent hypertension, renal impairment, and also gross hematuria. So next. So for principle management, to manage this patient, usually a normal protein diet with adequate calories is recommended. And when the child has edema, the salt will not be added to the diet. And we also can give the penicillin V, 135 milligram, for 1 to 5 years age, 150 milligram BD for patient 6 to 12 years old, and 500 milligram BD to patient more than 12 years old, and which is recommended at the diagnosis of nephrotic syndrome and during relapse, and particularly in the presence of gross edema. And also we also need to assess the hemodynamic status to see if there is any sign of hypovolemia and hypervolemia. The example for hypovolemia are abdominal pain, cold peripheries, poor periphery, poor pulse volume, with or without low blood pressure. For hypovolemia, such as vessel lactation, bronchi, hepatomegaly, and hypertension. So for fluid restriction, is not recommended except in chronic edematous state. And diuretic also are not necessary in steroid responsive nephrotic syndrome, but we can use it, but with caution if required, as the diuretic can cause hypovolemia. And also human albumin also can be used in symptomatic gross edematous state, together with intravenous furosemide to produce a diuresis to reduce the edematous state. And we also can give steroid therapy, and it is divided into two. The first one is initial oral prednisolone, which we give 60 milligrams per meter square per day for 4 weeks, and we followed by the oral prednisolone, which will be given alternately 40 milligrams per meter square for 4 weeks also. And then we taper the dose over the 4 weeks, and we stop the medication. And other measures that we can use by giving prophylactic antibiotics, which such as oral penicillin B, and also we can give pneumococcal vaccine to immunize the patient. So next. So for albumin infusion, as I said before, the albumin infusion only indicated if there is any chronic edematous state, and these are the doses that we give according to the situation. So you can read it after that. So next. So what happens is that majority of children with nephrotic syndrome will relapse, in which the patient can have nephrotic syndrome again, in which based on the diagram, it stated that only one third will resolve directly, and another one third will have infrequent relapse, and another one third will have frequent relapse, and also steroid-dependent nephrotic syndrome. So what is a relapse? Relapse in nephrotic syndrome is defined by urine albumin excretion of more than 40 milligrams per meter squared per hour, or urine density of more than 2 plus for 3 consecutive days. So if the patient had any relapse, so we will give the same medication as before, which is prednisolone, 60 milligram per meter square per day until the remission, and also 40 milligram per meter square, which we given alternately for 4 weeks, and then we stop the medication. So, so for the patient with frequent relapse, in which the patient have had 2 relapse within 6 months of initial diagnosis, or they had more than 4 relapse within any 12-month period. So for this patient, we also give the same medication as the patient with relapse, and then we taper and keep those alternate day prednisolone, which we give 0.1 to 0.5 milligram per kilogram per dose for 6 months. For the steroid-dependent nephrotic syndrome, this patient had more than 2 consecutive relapse that occurred during the steroid taper, in which the patient had the relapse when they are still on medication, on prednisolone medication, or within 14 days of the cessation of steroid, within 14 days after they stop the medication. So, if the patient had this steroid-dependent nephrotic syndrome, they will treat the same as frequent relapse, same as the patient which had frequent relapse, if there is no steroid toxicity. However, if there is any steroid toxicity, we can consider cyclophosphamide for the treatment. So the oral cyclophosphamide will be given 2 to 3 milligram per kilogram per day for 8 to 12 weeks. And the cumulative dose will be 168 milligram per kilogram. So if there are still any relapse post cyclophosphamide, so we give the same medication as the patient with relapse or frequent relapse if there is no steroid toxicity. However, if there is any steroid toxicity, we should refer pediatric nephrologist to consider other steroid sparing agents. So I think that's all from me.
Okay, all right. We leave the question after the end of presentation. Continue with the next one.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I'm Alicia Kalina, and I will proceed the presentation with acute glomerular nephritis. Okay, let's begin with the anatomy of the glomerulus. As you can see here, from the this is the efferent arteriole, and becomes a tuft of the capillaries called glomerulus, and with the efferent arterioles. And this is the podocytes, and this is JGA, juxtaglomerular apparatus. And if we zoom in, okay, basically for the glomerular basement membrane, it composed of 3 layers, which are the endothelium of the capillary, basement membrane, and also the epithelial of the Bowman capsule. This tree is known as the glomerular basement membrane. So the definition of AGN, or acute glomerular nephritis, is a sudden onset of inflammation and proliferation of glomerular tissue, which subsequently will cause damage to the basement membrane, mesangium, or capillary endothelium. Okay, what are the etiologies for AGN? It can be classified as primary or secondary. If primary glomerular nephritis, it is the disease that is isolated to the kidney, such as membranous glomerulonephritis, membranoproliferative glomerulonephritis, IgA nephropathy, antiglomerular basement membrane disease, or hereditary nephritis. If it is secondary glomerulonephritis, it is a systemic disorder which have a component that involve the renal, such as post-streptococcal glomerulonephritis, other post-infections such as HIV or any parasite or fungal infections. infective endocarditis, IgA vasculitis, also called Henoch-Schönlein purpura, or lupus nephritis granulomatosis with polyangiitis. For the next classification is we can be classified as infectious or non-infectious. For infectious, it can be bacteria, viral, fungi, or parasites. For non-infectious, it can be divided into multi-system or it just isolated to the renal disease. And the most common cause of AGN in children is post-streptococcal glomerulonephritis. Okay, this is the basic pathophysiology in AGN. There are some factors that contribute to the pathogenesis in AGN, such as in genetic or immunology disorder. For immunology disorder, they have two mechanisms, which are the first one, when there is the circulating immune complex that deposit in the glomerulus, or the second mechanism, when there's antibody in the bloodstream that will interact with the antigen in glomerulus in situ. It can be either the normal component of the glomerulus, or it can be other antigen that deposited in the glomerulus. So this deposition of immune complex, it can cause proliferation of the cells within the glomeruli and increase in the messenger matrix. And subsequently, it will increase in the glomerular size, and then it will narrow the capillary lumen and leads to renal insufficiency. And this deposition of immune complex also, it will activate complement system, which will then recruit inflammatory cells to the site and cause damage to the capillary wall, which will then presented with hematuria or proteinuria. And then this will disrupt the hemodynamic changes. And this narrow glomerular capillary lumen also, it can decrease the capillary perfusion, and then it will cause reduction in the GFR and sodium water retention. And this reduction in GFR, it will be presented as oliguria, and sodium water retention, it will present as fluid retention and exothermia, and eventually it can cause hypertension. Hypertension might be due to the fluid retention or because of the renin that has been excreted due to ischemic kidney. Okay, this is the renin-angiotensin-aldosterone system. As I mentioned just now, decrease in the renal perfusion, it will stimulate the JGA to release the renin. And this renin, it will convert the angiotensinogen to angiotensin 1, and then this angiotensin 1 will be converted to angiotensin 2 by angiotensin converting enzyme. And angiotensin 2 have many effects, such as it will stimulate the sympathetic activity and eventually will increase the blood pressure, and also it will increase in the tubular sodium chloride reabsorption and potassium excretion, also water retention. Then it will stimulate adrenal gland to secrete the aldosterone, which will cause sodium and water retention. Next is it will cause arterial vasoconstriction, which will increase the blood pressure. And the last one, it will stimulate the pituitary gland to secrete ADH, which will cause water absorption. So basically, the effects of angiotensin 2, it will cause fluid retention, water and salt retention, which will eventually increase in the blood pressure. So next, I will be focusing on acute post-streptococcal glomerulonephritis, as it is the most common cause in children, denotes 80 to 90% of the cases. It is a classic example of the acute nephritic syndrome, which commonly occur in the age of 5 to 12 years old. However, it's rare in the children less than 3 years old. And boy is more susceptible than girl. And for the acute post-strep to be happen, the patient should have history of streptococcal infection. Is either pharyngitis or pyoderma. For pharyngitis to develop acute post-streptococcal glomerulonephritis, it takes about 1 to 3 weeks. However, for pyoderma, it takes 4 to 6 weeks. As you can see the picture here, it's a pyoderma, it's a pharyngitis. And this diagram shows the pathogenesis in acute post-streptococcal. And when there's a streptococcal infections, there will be release of the nephritic associated plasmin receptor, which this receptor, it has the plasmin-like activity, which will induce the local inflammatory reactions. For the next pathogenesis, where this streptococcal bacteria, it will produce the SPEB, azoxystrobin B, which will stimulate the body to produce the antibody and forming the immune complex. And then this circulating immune complex, it will be deposited in the glomerulus, and it will induce the inflammation and activation of complement and activate the complement activation. Subsequently, it will be presented as has been mentioned just now. So the patient might be presented with a wide spectrum of severity from asymptomatic microscopic hematuria to oliguric renal failure. So the clinical features for the acute strep is a hematuria. It can be micro or microscopic. Normally, in the acute strep, for the first 2 weeks, the patient will be presented with gross hematuria, then followed by a microscopic hematuria for up to 6 weeks. And the color of the urine usually is brown, cola, or tea colored. It's because the presence of the red blood cells or because of the formation of the acid hematine. And usually the hematuria is painless. And the next one is the proteinuria. The patient might be complaining of proteinuria. However, for proteinuria in nephritic, it is mild compared to nephrotic syndrome. And the next one is edema. Usually the patient presented in the face and also the upper extremities, and can be presented as periorbital edema, usually in the morning. And also might be the patient might be complaining of the rapid weight gain due to fluid retention. Next is the hypertension. More than 50% of the patient with the acute post-strep will be presented with the hypertension. Usually it will appear for the first 4 to 5 days of illness. And the last one is the oliguria. It's defined as urine volume less than 400 milliliter per meter squared per day. So next, I will be explaining on hypertension in AGN. These 3 factors that contribute to the hypertension, which are activation of the RAS system, sodium or water retention, and also increase in the sympathetic activity. So the complication of the hypertension in AGN, it can be increase in the volume, in the fluid retention, which will cause heart failure and the pulmonary edema. Usually, and the patient might also be complaining of the dyspnea, orthopnea, PND, pulmonary crepitation, and enlarged tender liver. However, in the young children, ascites and the ankle edema is quite rare compared to older children. The next complication of hypertension is the hypertensive encephalopathy. When there is increase in the blood pressure, so that it will cause failure or loss of the autoregulation of the cerebral circulation, and it will cause the dilation, forced dilation of the vessels. When the vessels is dilated, so it will cause increase in the hyperperfusion. It will cause hyperperfusion, increase in the hydrostatic pressure, and end up it will cause brain edema. So the patient might be presented with irritability, headache, vomiting, blurry vision, temporary blindness, coma, or seizure. So this is the picture of the MRI of the patient with hypertensive encephalopathy, and the fundoscopy, as you can see, there is a flame hemorrhage, papillary edema, heart exudates, and cotton wool spots. And the last complication of hypertension is the acute renal failure with a persistent severe oliguria and anuria, which also can cause imbalance in acid base and electrolyte. So how to diagnose a patient with acute post-streptococcus is if the patient have this acute nephritic syndrome, including gross hematuria, which is sudden onset, edema, hypertension, and renal insufficiency. And if the patient have evidence of the streptococcal infection, when the patient have history of pharyngitis or pyoderma, and when the patient have presence of anti-streptolysin O titer and anti-deoxyribonuclease B level, and also when it involve the complement level, especially C3 in acute post-streptococcal. So this is the investigations in acute post-streptococcal. In UFEME, the patient, the expected finding is a darker urine color, specific gravity more than 1.02 because the urine is concentrated and oliguria, and presence of the red blood cell dysmorphic feature, presence of white blood cells, proteinuria, and red blood cell cast, which is a diagnostic for the nephrotic. And next is the full blood count, low hematocrit, and the patient also might have normochromic normocytic anemia due to hemodilution because of fluid retention or because of hemolysis. And for the renal profile is to look for the evidence of the renal dysfunction when there's increase in the urea and creatinine, hyperkalemia due to persistent oliguria, and dilutional hyponatremia. For the complement level in the acute post-streptococcal, the C3 level is low. However, it will return back to normal in less than 2 months. And then for the anti-streptolysin O titer is high. For the ASO titer, this one, it is more specific for, it can confirm there is a recent streptococcal infection. However, it's more specific in pharyngitis. However, in anti-DNase B antibody, it also confirmed the recent streptococcal infection. However, this one is more specific in pyoderma, which is the cutaneous manifestation of streptococcal infection. Next is the ANA, anti-double-stranded DNA to rule out SLE nephritis, anti-glomerular basement membrane antibody to rule out the good pasture syndrome, throat swab, presence of beta-hemolytic streptococcus, and MRI brain to look for the evidence of intracranial bleeding or there's a brain edema, and chest X-ray, look for the signs of heart failure, pulmonary congestion, and edema. And renal biopsy is indicated in patient with acute renal failure with a nephrotic syndrome, absence or no history of the streptococcal infections, a normal complement level, or the C3, they have low C3 level but more than 2 months. That has been mentioned just now. For the acute post-streptococcal, it usually will return back to normal in less than 2 months. If more than 2 months, we need the renal biopsy is indicated. So this is a picture of renal biopsy. As you can see, on the left side is a normal glomerulus. In the middle, on light microscopy, it shows hypercellularity. As you can see, increase in the inflammatory cells. And on the right side is immunofluorescence. It shows the position of the immune complex in the capillary wall. Okay, in this slide, it shows how the causes of the AGN can be differentiated based on the C3 and C4 value. As you can see, the causes acute post-streptococcal, lupus, glomerulonephritis or SLE, and also the mesangial capillary. These three usually it will affect the plasma serum of the complement level. For the acute post-streptococcal glomerulonephritis, since it will activate the alternative pathway in the complement system, which only involve the C3 and BB, as you can see here, C3, BB. So that's why, because of the use up of the C3 complement, so the value will be low, low C3 level. However, since the alternative, they have no C4 involvement, so the patient might have normal C4. Same with the mesangial, low C3 and normal C4 because of the alternative pathway. However, for the lupus glomerulonephritis, SLE, it will activate the classical pathway due to the deposition of immune complex, which will involve C2, C4, then C3. So due to the use up of the C2, C4, and C3, that's why the value for lupus is low C3 and C4. So for the principle of management in the acute post-streptococcal glomerulonephritis is to treat the acute effects of the renal insufficiency and hypertension by strict monitoring, fluid intake and output chart, daily weight and blood pressure monitoring, bed rest usually until the acute phase is resolved, okay, usually about 2 weeks, and then fluid restriction to control the edema and secretory overload due to oligonucleotide phase until the child diuresis and the blood pressure is controlled. Next is diuretic. For example, is furosemide in pulmonary edema or hypertension. As for hypertension treatment, we can also prescribe with antihypertensive drugs such as ACEI and ARBs. Also can also calcium channel blocker. And for diet, low salt intake, and also oral penicillin for 10 days to eliminate any residual streptococcal infection. And we also need to monitor the risk of complication of the hypertension, such as hypertensive encephalopathy, pulmonary edema, and acute renal failure, and we need to manage accordingly. Okay, that's all. This is my reference.
Okay, all right. Proceed next one.
Okay, next, I will present about urinary tract infection. Next. So the definition of the urinary tract infection, it is an infection in any part of the urinary system which consists of kidney, ureter, bladder, and also urethra. However, most of the infection involve the lower urinary tract, which is the bladder and also the urethra. UTI also can be defined as a combination of clinical feature and also presence of the bacteria in the urine, which the bacteria in the urine must be more than 100,000 colony of single organism of the freshly urine. There are two types of UTI, which are acute pyelonephritis and also acute cystitis. For the acute pyelonephritis, the patient should have bacteriuria and also fever more than 38 degrees Celsius, accompanied with a loin pain and also tenderness. And this acute pyelonephritis carries higher risk for renal scarring. For the second type of UTI, which is acute cystitis, it is an infection of the lower urinary tract accompanied by acute voiding symptom, for example, dysuria, urgency, suprapubic pain, and also incontinence. Next. For the epidemiology, 75% of infants younger than 3 months old with bacteria are male, and the prevalence of UTI varies with the age. For example, in the first year of life, boys are more common to have UTI compared to girls due to the colonization of the uropathogen at the periurethral area. And then, however, after 1 year of life, girls are more prone to get UTI compared to the boy because of the short urethra. Next. So for the common organism, 90% of UTI are caused by E. coli. And then second most common organism is Klebsiella, which is more common in young infant. And then followed by Proteus, which is common in male. And then because these organisms are present under the prepuce of the penis. And then followed by the Pseudomonas aeruginosa and also Enterococcus bacteria. Next. For the risk factor, first is sex, which is female are more common to have UTI compared to the male because of the short urethra. Second is voiding dysfunction, which it is characterized by withholding of both urine and feces, which cause urine stasis in the bladder and promote infection. And then uncircumcised male, which is in the first year of life, boys are more common to get UTI compared to the girl because in uncircumcision, there is a bacterial infection at the foreskin during the first 6 months of life. And then the colonization will decrease after that maybe due to the foreskin become retractable. So that's why during the first year of life, boys are more common to have UTI. Next is obstructive uropathy, vesico-urethral reflux, wiping from back to front in girl because it will bring bacteria from the rectum into the urethra. Next is toilet training and also pinworm infestation. Next. Okay, for the one of the risk factor of UTI is vesico-urethral reflux. So it is a retrograde flow of urine from the bladder into the ureter and also collecting system. This vesico-urethral reflux has two types, which is primary and also secondary. For the primary, it occurs due to the congenital anomaly of the uretrovesicular junction. For the secondary, it occurs due to the high pressure voiding, for example, in the case of posterior urethral valve, neuropathic bladder, and also voiding dysfunction. And then this disease is the commonest radiological finding in children with UTI. And this disease also can lead to the renal scarring, end-stage renal disease, and also hypertension. Next. For the pathogenesis, there are three pathogenesis that contribute to the urinary tract infection, which are ascending route, hematogenous route, and also lymphatic route. Next. So usually the most common route is ascending route. In healthy patient, most of the uropathogen originate from the rectal and then it will enter the urinary tract via the urethra into the bladder. And then for the hematogenous route, it is uncommon. However, it might occur if the patient is having bacteremia. For the lymphatic, it is also uncommon, but it usually associated with the lymphatic, usually associated with the retroperitoneal abscess and also severe bowel infection. Next. For the clinical manifestation of UTI, the clinical manifestation depends on the age of the patient. So for example, in a newborn patient, the symptom is quite unspecific. For example, fever, failure to thrive, feeding problems, and also jaundice. For the infant and young children, the symptom is fever, failure to thrive, feeding problem, diarrhea, vomiting, and also gastrointestinal illness. For example, colic, irritability, and screaming period. For the school-age children, the symptom is fever, diarrhea, vomiting, anorexia, hematuria, dysuria, urgency, frequency, and also abdominal and back pain. So basically, for the school-age children, the symptom is quite similar to the adult UTI. For the diagnosis, next. For the diagnosis and investigation, the diagnosis of UTI is best made with a combination of culture and also urinalysis. So first we have to know how to collect the urine sample. There are several methods that we can do to collect the urine sample. For example, back urine specimen, which is back urine specimen. However, this method has high contamination rate, which is up to 70%. Second is clean catch specimen, which is usually used for the toilet-trained children. Next is catheterization. This method has low contamination rate and also less painful compared to the supra-PV aspiration. And last one is supra-PV aspiration, which is this method is a gold standard, but it is highly invasive. Next. So for the investigation of UTI, first we can do deep stick test, which we can. So under the deep stick test, there are several things that we will test, which is leukocyte esterase, nitrite, pyuria, and also bacteria. So if the patient has positive leukocyte esterase and also nitrite, so this patient is highly to get UTI because these two marker has high sensitivity and specificity. Second is urine culture and sensitivity. So urine need to be cultured within 4 hours to prevent any bacteria growth that eventually will contribute to the false positive result. So if we cannot culture within 4 hours, we have to refrigerate the specimen. And then next is full blood count. We can see the evidence of the elevated white cell count in the case of UTI. And then renal function test, we look for the urea and creatinine level. Next. Okay, for the recommendation for imaging, not all children with UTI, we should do imaging for them. So there are several modalities for UTI. First is ultrasound. For ultrasound, we can see the size, the location of the kidney, and also bladder anomalies. So for the recommendation, all children less than 3 years old, children above 3 years old with poor urinary stream, serious ill with UTI, palpable abdominal mass, raised serum creatinine. So this is the picture beside the table, the picture of ultrasound of kidney, ureter, and also bladder. Next is DMSE scan, dimer captosuccinic acid. Usually this scan done after 2 to 3 months after the successful treatment of UTI. And for the recommendation, seriously ill with UTI, poor urine flow, abdominal or bladder mass, and also raised creatinine level. So this is the picture of the DMSE scan. So next, so what is DMSE scan? It is a chemical that will be injected into, which is dimer captosuccinic acid, will be injected into the body, and then this chemical will be taken up by the kidney, and then this chemical will be linked with the radioisotope, and it will emit the gamma ray. So the principle is that when the kidney cell are active, it will take up the chemical and then emit a brighter image, while the less active kidney cell, it will take up less or none of this chemical, and then it will produce less bright image. So so that's how the MSEs can work. So the MSE scan can look at the size, shape, position of the kidney, and also check for any scar and also abnormal area of the development of the kidney. Next imaging is diethyl triamine pentacetic acid, DTPA scan. So it is used to diagnose and also evaluate the kidney function. It involves intravenous administration of the radiopharmaceutical material to assess the drainage pattern of kidney and also to find out if any area is not functioning properly. So this is the example of the DTPA scan. Okay, next. Okay, for the management, all infants with febrile UTI should be admitted and IV antibiotic should be started. So the antibiotic treatment for UTI is depend on the type of UTI. Either the patient is having acute cystitis or acute pyelonephritis. For the acute cystitis, the preferred treatment we give oral trimethoprim for 1 week, and then for the acute pyelonephritis, we give IV ceftriaxone for 10 to 14 days. Next, for the asymptomatic bacteriuria, no treatment recommended. Okay, lastly, for the antibiotic prophylaxis for UTI, usually this antibiotic prophylaxis is not routinely recommended for the first time of UTI. However, it is recommended for recurrent symptomatic UTI and also vesicoureteral reflux grade 3 and above. So the recommended treatment for antibiotic prophylaxis is oral trimethoprim. That's all from me. Thank you.
Okay, all right. Okay, all right. Any question?
I have a question.
Yeah.
How UTI cause jaundice?
How?
UTI cause jaundice in the slides.
No, the other way. It's not UTI cause
Jaundice
jaundice.
cause UTI.
Not jaundice cause UTI. Patient with jaundice need to be investigated for UTI, for prolonged jaundice especially. We're talking about prolonged jaundice, cause of prolonged jaundice in newborn. You need to investigate for UTI because one of the cause of prolonged jaundice is actually urinary tract infection. Okay. And I think I want to emphasize on the hypertension because the way that you differentiate nephrotic versus nephritic or AGN is actually hypertension. So rarely or almost no patient with nephrotic syndrome come with hypertension because the pathophysiology is different. They can present with hypotension, right? Pure nephrotic syndrome, they don't have hypertension. So if patient comes with edema, proteinuria, and hematuria, but no hypertension, so the likely diagnosis in your exam or in real, it should be nephrotic syndrome, as compared to those who presented with a big proteinuria, hematuria, and have hypertension. This is definitely acute glomerulonephritis because the pathophysiology is different. Okay, so quite straightforward. If you want to differentiate between, in most instances, if they have hypertension, it is AGN. Okay, if they don't have hypertension, okay, grossly edema, they may have a bit of hematuria, but gross hypoalbuminemia, then it is likely a nephrotic syndrome. So in exam, you may have this situation. Okay, so you should be very clear and look at the chart, ask them whether they got blood pressure or not. Okay. So any question with regards of the three presentation?
I have a question. How does immune complex it can cause proliferations of the cell within glomeruli?
Who's the presentation? You want to answer?
From what I read, the position of immune complex, it will promote some release of the cytokines that will cause proliferation of the cells in the glomeruli.
Okay, can you show the immunofluorescent picture just now? Okay, so imagine immune complex is actually an army. Supposedly, it's supposed to protect your body, right? But the immune complex actually it's like just now in Lebanon, right? You saw? Actually, it's like an atomic bomb. Sorry. So it's like an atomic bomb. It supposed to protect your body, but it blasts out everything surrounding. Okay, so the effect of the blast actually creates the second. The first time that you saw the Lubnan video just now, it's like a cloud initially. That is the first time, and secondly, you have the spread of the cloud. You know, the spread of the cloud is the cytokines and other other mediators which is damaging and causing proliferation. It means actually injured the basement membrane and make it what you call this permeable, so blood and protein can escape from there. Okay. Any other question?
Doctor, I want to ask, why in nephrotic syndrome, when there is a gross edema, we need to give penicillin?
Right. Any idea? The first presenter. You can explain it with regards of the pathophysiology as well just now. When hypoalbuminemia, you look at again the slide when you discuss about the pathophysiology. Right. You can't see my PowerPoint pointer, right? Because you are the only one who can see it. So what happened is actually, see the, yep. You look at the when you lost your protein or lost your albumin, what indirectly is lost in the urine as well? What do you think? What part of immune system is lost in urine as well?
Globulin.
Complement.
Yes, lagi. Globulin lagi. Your antibodies are protein, isn't it?
Yeah.
Okay. So you have a relatively low antibodies. Okay, so that is relatively. So, what type of organism then will take this opportunity to infect people with this low? What specific organism in this situation? Which is encapsulated organism. You've learned in microbiology, and so encapsulated organism. One of them is Streptococcus. So that's why we give penicillin, okay, as a treatment initially, as a treatment to prevent spontaneous bacterial peritonitis, okay, and prevent the what you call this strep infection, okay. All of these question are actually exam question. You got nephrotic AGN is a question that we're gonna ask you. Pathophysiology, definitely. We ask you pathophysiology of hypertension in AGN. We're gonna ask you. So briefly, you have to explain, right? So what is actually the mainstay of treatment for hypertension in acute glomerulonephritis? If you know already the pathophysiology, what do you think is the best treatment for hypertension in AGN?
ACEI.
ACEI? Oh, I look.
ACEI.
No. What is it just now? You look at the salt and water retention, isn't it? The main pathophysiology. Because of the activation and renin-angiotensin, you got salt and water retention. That's the cause of edema in AGN. It's different from edema in nephrotic, isn't it? So edema in AGN is due to salt and water retention. And because of that, they got volume expansion. Because of that, you got hypertension. So what's the best treatment of hypertension in AGN?
Diuretic.
Yeah, diuretics. Right? So despite if you see even the urea and creatinine is elevated, if you are sure this is what you call this AGN, we still give diuretics because then only your renal function will improve. Because the pathophysiology is different. So it is very clear. That's why you must be very clear. Otherwise, you can give a different treatment, you misunderstood it. So need to understand the pathophysiology of nephrotic and AGN is different. Okay. Other question? All right. No other question. Okay. No question. Then I think good. We end up with Tasbih Kifara and Surah Al-As. And please, I'll message you. Please email me the slides. I think that's all. Okay. Assalamualaikum warahmatullahi.
Thank you, Doctor.
Salam. Thank you,
Thank
Doctor.
you, Doctor.
Thank you, Doctor. Thank you, Doctor. Thank you, Doctor. Thank you, Doctor. Terima kasih.